Now I have the pleasure of introducing Dr. Elizabeth Rodriguez, who has been a nurse for nearly 20 years with most of her experience in the outpatient oncology setting. Dr. Rodriguez is a graduate of Villanova University's College of Nursing, has a Master's of Arts in Nursing Administration from NYU, and in 2010, Dr. Rodriguez earned a Doctorate of Nursing Practice degree from Duke University. Currently, Dr. Rodriguez serves as a nurse leader in the outpatient setting at Memorial Sloan Kettering Cancer Center. And as a nurse leader, Dr. Rodriguez works directly with the Interprofessional team to manage clinical operations for leukemias, hematologic diseases, and bone marrow transplantation in adults in the outpatient setting. She participates in projects related to the center's strategic plan, which includes the development of innovative care delivery models to meet a growing patient volume, complex clinical trial, regulatory requirements, as well as the changing healthcare landscape. Over the past 10 months, Dr. Rodriguez has been a key leader in the development and implementation of the CAR T-cell program for the commercialized CAR T-cell products, and she's here today to give us the nursing perspectives of cellular therapy. Please welcome Dr. Rodriguez.
Hi, good afternoon. I'm so happy to be here today. It's my first time in Seattle, so I want to thank Karen Anderson for inviting me out here and Val Sawyer for helping me to get here today. I also want to add that I have a colleague who will be joining us via video later in the presentation, and that's Karen Cullum. I added her name to the introductory slide. The first time I ever presented on CAR T-cell therapy was 10 months ago. As my introduction stated, I am a nurse leader who's worked with bone marrow transplant services for about the last 8 years. But I haven't really been involved in our CAR T-cell programs or clinical trials, even though at Memorial Sloan Kettering we've been involved for over a decade. As the commercial products were being approved last fall, I was then charged with the responsibility of helping to build the program for the commercial CAR T-cells. And as I was preparing to present the first time, I took some advice from a colleague of mine at work who said, talk to somebody at home, one of your family members, and really try to simplify what CAR T-cells are. So naturally, I talked to my daughter, who was 8 years old at the time, and explained to her all about CAR T-cells and how they were helping patients with cancer. And at the end of the explanation, I asked her to repeat back to me, naturally, to assess what she had learned. And she said to me, so basically, Mom, you're taking cells out of people, you're dressing them up in fancy clothes, and then giving them back to them again. And I said, that's basically what it is. So today we'll talk a little bit more about what it means to build this program for these type of therapies. These first set of slides actually were developed by Dr. Sergio Giralt, who's the physician chief for bone marrow transplant at Memorial Sloan Kettering. He developed some principles to help guide the development of this commercial program. First, and we've talked a lot about this today, is about access to care. We wanted to develop a program that was going to be able to serve as many patients as possible in a safe way. So we're balancing access by providing care in a specialized facility, but to as many patients as we possibly can. We've also talked about this, and we heard about it this morning from Dr. Applebaum, that we don't want to compromise our research agenda. So it's important that we have support for ongoing clinical trials and programs so that we can look to improve these outcomes even more. Third, and this has also been mentioned many times, the importance of the interprofessional team. So we wanted to first identify who all those stakeholders were, and then engage those stakeholders in a very meaningful way. We have a very rich history of transplantation at Memorial Sloan Kettering and a huge program. We knew that we could leverage some of those resources in the development of the commercial CAR T program, as well as some of the learnings from our clinical trials experience, so that we would avoid any sort of duplication of efforts. And lastly, we really wanted to use this as an opportunity to advance our research agenda and maintain our leadership in this field. So this slide highlights some of the key differences between the research and commercial programs. So first off, we knew, or we at least imagined, that we were going to have to manage patient expectations. Many patients accept the fact that when they're enrolled in clinical trials, there's strict eligibility criteria and there's limitations around access to spots. But for a commercial product, the public has different expectations. They might imagine that the eligibility would be a little bit looser and there would be broad access to care. As we learned this morning, there could be some loosening of the criteria to receive the therapy, but insurance companies may not always pay for it. The next item was patient volume. So in clinical trials, the patient volume is restricted. But again, as the commercial products became available, we wanted to ensure that we had a program that could scale and also sustain the volume that we might be expecting. And this, in large part, required us to have a very detailed infrastructure in our documentation systems. And I'm going to share a little bit about what we're doing with that later on in the presentation. Initially, we thought that the research patients had a less complex intake process. But in reflecting back on that, I think the intake processes are equally complex. In research, there's a lot of work that's done, again, around the timing of the spots for patients to be able to enroll in these trials. And in the commercial world, the complexity is coming from the insurance authorization component. Reimbursement, we've heard over and over again today, is a huge issue. And when patients are enrolled in trials, in large part, the product is covered. But when you're receiving a commercial therapy, there's a huge cost that for the patient, and then also significant financial risk for the institution. Lastly, reporting requirements. Again, for patients on clinical trials, you're responsible to report to the sponsor, but in the commercial products, there's that expanse, and we have an obligation to report through the FDA and CIB-MTR. So some of the best practices we've learned is that we need to develop some clear information sheets for referring providers. At MSK, this is something that's actually still a work in progress for us, and that's large part because the patients that we've had receive the commercial products to date have all been internal referrals. We also know that referral calls should be directed to experienced nurse coordinators and nurse navigators. And this is sort of a conundrum because there's not a lot of people that are experienced with these commercial products. So again, we turn to our bone marrow transplant program where we have a rich history of clinical nurse coordinators working to coordinate care for patients. And we actually have leveraged those nurses to be a part of this CAR T-cell program. Consenting process. Again, we knew that we wanted to give a very clear message to patients about the benefits, the risk, and the financial implications for either enrolling in a clinical trial or receiving the commercial product. And we needed to ensure that we did this in a very consistent way across the interprofessional team. So we actually worked very close with our legal team in developing some specific talking points so that we could ensure that when the physician met with the patient and then the nurse and then the social worker, that we were all speaking the same language. We also decided to leverage our bone marrow transplant intake team to do the intake for our CAR T commercial program. And this involves care advisors that are answering the phones and the clinical nurse coordinators who are then reviewing eligibility for treatment. We then put together a multidisciplinary team that included colleagues from patient financial services and finance who were specifically dedicated to these nuances of CAR T therapy. And then with Kite and with Novartis, it's extremely important to have close and frequent contact with the companies. So knowing who those people are at the companies and setting up a schedule for communication is really important. We know that there's not really a one-size-fits-all solution, and many centers are approaching this in different ways. At MSK, the CAR T program is part of the bone marrow transplant service. Over the next 18 months, as we see how volume grows, we may consider creating our own CAR T-cell service, but we expect that it will always be very closely tied to bone marrow transplant because we have a good infrastructure in place there, and a lot of the reporting and quality requirements are the same. I've already talked a lot about the clinical nurse coordinators. We also wanted to ensure that we worked closely with our critical care colleagues, ICU physicians, inpatient nursing services. Pharmacy is a big part of this, and I know there's a pharmacist speaking later today, but really new on the scene for CAR T therapy. When in the clinical trial world, we really just worked with our cellular infusion folks. Now we're bringing pharmacy into the mix, and so that was a new frontier for us. We established weekly CAR T meetings that are multidisciplinary, and we meet every Monday at 9 a.m. The purpose of this group is to review ongoing issues related to workflow, what the education needs are of the staff, and understanding what sort of the dashboard is of patient referrals coming into the program. This is a snapshot that I don't expect you to be able to read the details, but I wanted to give you a flavor of what we look at every Monday morning at 9. It tells us the total number of referrals we've gotten into the program. You can see that up at the top in gray, 66 patients at the time that we made these slides. And down below in the green circle, we've had 18 patients that are in progress for receiving commercial CAR T-cell therapy. So communication is key. Communication internally and externally with the manufacturers and also within the organization around patients who are receiving these therapies. We're still working on our SOPs for staff that are working at nights and on the weekends. We have hospitalists, and that is all still a work in progress to ensure that they're following all of the guidelines appropriate for the care for these patients. So now I'm going to talk a little bit about how do we actually bring patients in for therapy. And to do that, I'll go through 8 essential tasks. So number 1, patient is identified by their referring provider as a possible candidate for CAR T therapy. We actually established a 1-800-MSK CAR T phone line that providers can call, and that call is received by a patient care advisor. Some initial intake is done, and then that call is passed on to our clinical nurse coordinators. Patients then come in for consultation with our specialized group of CAR-enabled physicians, and there's a decision made upon treatment. We go on for collection of cells, shipping of the cells, and manufacturing. There's a bridging strategy for the patient depending upon their condition and disease status. We infuse the cells, and the patients are monitored for up to 30 days by our CAR T physician team. After 30 days, patients are referred back to their primary oncologist. So this is, I'm going to let the animation go for a moment here until it. This is more of a schematic of the 8 essential tasks that I just described, so I'm going to go into a little bit of depth here. Sorry about that. Okay. So as I mentioned, the patients are initially screened by our patient care advisors, and sorry about the animation, and then the nurse is reviewing the patients in much more depth. So what I'm trying to get the slide to stay still for is showing you that the nurses are reviewing eligibility criteria with patients. They're going through the records, and then they're making a phone call. And we think this is really important because sometimes what you see on paper isn't the reality of how the patient condition. The nurses also use this phone call as an opportunity to start education with the patient and exploring what their social support is. So we know these patients need caregiver support and that they need to live close by. We'll just go with the animation here and figure it out. Okay. This can be a challenge, the staying close by piece, especially in New York City where costs are high. We do have Hope Lodge in Manhattan, but not all patients are able to stay there, so that's sometimes a barrier to care. The clinical nurse coordinator then is working closely with the patient, our donor room, and the cell therapy lab to plan for treatment. And they're also coordinating with the manufacturer, Kite or Novartis, and then at the same time with the insurer. So although this looks like a linear process, it's actually tasks that are being done in parallel. Cells for Kite are stored in a nanocooler, and then they're delivered to the company. We know that they can take 17 to 21 days to manufacture, and so there's a lot of communication between the clinical nurse coordinator and patient during this time, whether they're internal or they're external referrals. Our patients are being managed on the transplant service by our transplant physicians. We've had 11 patients to date receive Yescarta, and all 11 patients have been admitted to the hospital. And as I mentioned, we're monitoring them for those first 30 days and then referring them back to their primary oncologist. So I'm going to take a moment to listen to Karen talk a little bit about quality monitoring for these commercial products.
Hi, I'm Karen Collum. I'm the nurse leader for nursing quality and the transplant services. And I'd like to take the opportunity to talk to you about CAR T cells and quality. With any programmatic development or implementation of new practice, we always strive to ensure a seamless process for the patient as well as provide the highest quality of care. This quality foundation is what makes MSK able to integrate new concepts effortlessly and remain one of the leaders in our field while continuing to raise the bar. Our CAR T-cell program is an excellent example of this process. Woven through all of the workflows, the quality practice and policies currently under development have many similarities with our existing stem cell transplant program and can be used as guiding principles. For example, the stem cell transplant program is essentially self-regulated by the Foundation for Accreditation of Cellular Therapy. This organization was developed by transplanters with the specific aim to establish standards for high-quality medical and laboratory practice in cellular therapies. Similarly, a group of experts in CAR T-cells was convened, and in March 2017, FACT released the first edition of standards specific for immune effector cells. The overarching quality umbrella is continually monitoring activities for three distinct purposes: auditing, outcomes, and reporting. Auditing allows for us to ensure that we follow established practices and workflows, helps identify areas for change, and confirms compliance with regulatory standards. Some examples of auditing include clinical documentation. All infusions require a specific form to be documented. We would confirm this form is completed and the accuracy of the data. Donation workup process. MSK is required to perform specific testing within a specified time frame. We review patient records to confirm we are meeting this requirement. Products with positive microbial cultures. MSK must track the frequency and, if any, the management of these types of products. Another area for monitoring is volumes and outcomes. While we will undoubtedly want to track how many patients and the success of the treatment, we will also be required to report this information externally. This brings me to internal and external reporting requirements. We continually monitor the number of patients receiving treatment. With FACT accreditation, we would be required to provide this data. Additionally, there will be other regulatory agencies and third-party payers requesting this information. We all recognize the exciting opportunities associated with CAR T-cell therapy, and we also understand there is some ambiguity and some things we are still learning. With so many services and departments associated with the expansion of CAR T-cells, from a strong research footprint into a standard of care, we acknowledge and thank everyone involved who recognizes the importance for care coordination.
So as I mentioned, to date, we have treated 11 patients with Yescarta. This slide, the key thing about this slide I really want to demonstrate is the time to get prior insurance authorization. So that is depicted in the dark green. We've had a lot of variability, and you can see that from the graph, dependent upon the payer that we're working with. We also have achieved many single case agreements. We have a contract, but regardless, we know that the payers are really still struggling with developing their policies around how they're going to reimburse for these therapies. So we're seeing that the prior authorization can take, several weeks. We had one that took a month, but on average, it's about 12 days at this point. And here we have a comparison of length of stay. So we've had 11 patients receive therapy, 8 patients have been discharged, so that's why this slide shows the 8 patients. The dark purple is the length from infusion to discharge. And again, here again, you can see some variations, but I think what is really compelling here, and we discussed earlier this morning, is the burden of resources of having to admit these patients to the hospital. Many of the patients required ICU admissions as well. And so there's, additional considerations around cost of care. Believe it or not, when we first were thinking about Yescarta, we thought we might treat our first 3 patients inpatient, gain a little bit of experience, and then explore administering the therapy outpatient. So we quickly learned that that wasn't going to be possible, and that really has a lot of implications and requires you to be pretty nimble, which I'm going to keep talking about in future slides. But this is, I think, very compelling around what the patient experience is and also the burden of therapy. So now I want to go into, 10 months later, a little bit of the then and now, what we imagined we might experience and what we've actually learned from the experience. So first we'll start with the finances. And I'll say this too, there's still a lot of unanswered questions. So, I think that we're still learning a lot about the financial impact for patients. And I would say we know very little about that at this point. And then also for the institution. So we've had a couple of patients treated who had Medicare. 3 patients were Medicare patients. And we're only just now starting to actually get some reimbursement in for some of our other patients. So this is really unknown territory still at this point. I talked about nimble staffing strategies. So, 10 months ago when we imagined we might do some of this work outpatient, we did some planning around resources and where those resources might be allocated, inpatient and outpatient. We really have to be very flexible as these programs are evolving, because as soon as we learned that that wasn't going to be an option, we had to sort of rethink that allocation of resources. And then now again, we have Kymriah more recently approved, and with the hope that we might actually be able to keep some of these patients out of the hospital. So again, thinking about how does that impact our staffing strategies, and just again, being very nimble around that is important. We also made a lot of predictions about enrollment onto clinical trials versus the patients that would proceed with the commercial products. And I think the lesson learned there is that's difficult to predict, and that's in large part to the clinical trial, spot availability, the timing of the availability, and things like that. So that's another piece that, it's been, as much as we try to put in algorithms to predict what might happen, the reality is that some of these things are just not going to fit into those algorithms. From a logistics standpoint, as I mentioned, we have very close and frequent contact with Kite and Novartis, and that's been an interesting experience. And Lindsay talked about this in her discussion this morning about apheresis, and one takeaway I took from her talk was just variation and how all the clinical trials have so much variation. Well, the commercial products just introduce yet more variation, and each company has their own way of doing things, right? So with Novartis early on, with the pediatric product for ALL, they were largely on paper. We were filling out requests for products on paper and scanning them and emailing them, while Kite had an online web portal that we were using. Since then, Novartis now has an online portal, but the two portals are quite different in look and functionality and access. One workflow we most recently worked on was the verification of the orders. So there's a two-step verification process, and we're giving feedback to the companies about what makes sense for those processes, how that integrates into our workflow, and that's been extremely helpful because they've been responsive to some of that feedback. So I think that's really important. And again, something Lindsay talked about was, this idea that you're not just beholden to the manufacturer and the company, and that it really is a partnership, and we have to say, how we can do things together. There has to be some flexibility on both sides. Reminds me, another piece to that is the timing of collections. Being in New York and working with Kite, who's out in LA, we are restricted to when we collect because of the last flight out of New York, 6 p.m. from JFK, and the realities, my Montefiore friends I think are up here, so the realities of getting from Manhattan out to JFK on a Friday afternoon in the summer and making flights, it's just, there's just certain things that you have to really think about with that. So that's another piece to the workflows. One other thing we learned in communicating with these companies is that there's sometimes drift. So while there's the web portals, there's also email communications happening, there's telephone conversations. I think everybody has the best intention of possibly over-communicating about how we're managing these patients. But when that happens, what we've experienced is sometimes a little bit of drift around established workflows. So an example of that was, working with one of the manufacturers and communication coming in directly to our clinical nurse coordinator, which isn't really a reliable and sustainable way to communicate when nurses can be out sick and on vacation and things like that. So having to go back to the companies and really say we need to adhere to the workflows and processes that we have established at MSK, which is phone calls come in through the primary physician's office and then they get triaged to the nurse accordingly. The care coordination cannot be underestimated. Our clinical nurse coordinators, for the commercial products are really challenged with this insurance authorization piece. There's a desire to try to start to set up appointments for cell collection in the donor room and possibly if they need a line placement, and then looking out to the cell therapy lab schedule and admission schedule. But really none of that can start until you've received that insurance authorization. And we've had a couple of instances with our first 11 patients where some of those pieces and appointments got scheduled before the authorization. Everything worked out okay, but the risk there is if you don't have really robust communication internally, is that a patient could present for collection prior to us actually having the authorization in place. So it's very complex in terms of managing sort of air traffic control as the nurse coordinator. And then patient expectations. So, understandably, patients want access to this therapy, and they're, very eager to be a part of something that can help them. We had an example of a patient who provided us with their secondary insurance with a mistaken belief that that would be better in terms of coverage for them. We only came to learn that after 2 weeks process of us getting authorization from their secondary insurance, and then learned that they hadn't supplied us their primary insurance. So being very clear with patients about the authorization process, the coverage, the benefits, the costs, and being very consistent in that communication is so important. So documentation, we've partnered really closely with our health informatics and nursing informatics teams to think about documentation, and I find this very exciting because it's, the whole thing is exciting, really building a program from the bottom up. But looking at documentation through a different lens for us and thinking about it across the continuum, so understanding that these patients will be in the hospital and out of the hospital, and being flexible around that, and then thinking about what the documentation really looks like and supporting that sort of patient flow through the care continuum. So first we developed and this isn't quite live yet, but we have a form that the clinical nurse coordinator is using for that initial patient intake. So after the review of records, they're making that phone call to the patient to clarify what they've seen and to amplify the information. And so we have a note that they're using in the record to document that telephone call and capture the patient education that they're doing. There's a pretreatment checklist. Here we had something in place already for bone marrow transplant patients, and it was working really well. So we just integrated that note and renamed it for all cellular therapies. Next thing we came up with was a way for assessing neurotoxicity. So again, in the clinical trials, this is spelled out pretty carefully in each of the protocols. But for the commercialized products, we wanted to ensure that we had a standard way of assessing for neurotoxicity across the continuum and from provider to provider. So we came up with an internal scoring system called the SCAN score. I'm going to show that to you on the next slide. So we had to actually develop a SOP for that and then the associated documentation. It's pretty cool because the documentation actually has alerts embedded into it, so it's smart. And if you reach certain scores and certain toxicities, it's alerting you so that you know you need to escalate the care. Similar to how we've built sepsis alerts in our documentation. And then lastly, we have a desire to have a patient dashboard. So what I showed you earlier was really just built out in Excel, and that sort of gives like an overview of patient referrals. But what we'd also like to be able to do is pull information from the electronic medical record about each individual patient in the CAR-T process. So that would actually, depict where the patients are from referral up until infusion and what things have been completed in terms of, workup along the way. So that is something we're also sort of modeling after what we've built for bone marrow transplant and trying to build that as well for the CAR-T patients. So this is our SCAN score. It's an internally developed assessment tool. It stands for Screening for CAR-Associated Neurotoxicity. The level of toxicity is graded by the score results. And as I said, it's going to assist the provider in choosing the next steps in treatment. We're assessing patients at baseline on day 0 through day plus 14. If they're in the hospital, they'll get assessed once per shift. If they're out of the hospital, it'll be once per visit. We haven't treated patients out of the hospital yet, but this is an area of interest for me, and I think, notably represents a difference in care. And so some of the things that we're thinking about is how do we ensure that once we start doing this as an outpatient, that patients are being assessed and monitored to the degree they need to be when they're home. And so are we using some patient-reported tools, electronic tools while the patients are in the home, or some wearable devices for remote monitoring and things like that. So that's what we're imagining. So we've only just come to some agreement on our SOP for toxicity, and that's really related to how fast things change. And so we've literally written and rewritten these SOPs, and really coming together as an interprofessional team about what they should be. And I think that's just it amplifies sort of what all of this has been for all of us, and showing that how quickly things are evolving and changing. I think that this piece here around, standardizing the care is so important, and I don't know to what degree we'll be successful in doing that, but again, I go back to thinking about Lindsay's talk this morning and the degree of variation that exists around how we're monitoring and managing these patients receiving these therapies. And I always was taught that variation is the enemy of quality. And so I think this is something we have to really keep a close eye on as we move forward. And to the degree that we can standardize how we're assessing patients for toxicity and how we're managing patients for toxicity, both in the research and commercial, administration of these products, then I think we'll be better off in terms of ensuring good quality care. And then, of course, with Kimrai, again, thinking about outpatient treatment again, it's sort of we think about it and then we don't think about it and we think about it again. So it's exciting to, have that option for patients, but there's also a lot of considerations that come along with outpatient treatment, not to mention the idea about monitoring patients at home or educating them to assess themselves for side effects, but also the requirement to be close by to these centers. And as I mentioned earlier, in New York City, this can be a real challenge for patients to be close by and, just represent another issue around access to care. So what we're trying to do in this slide here is just really illustrate the impact of the multidisciplinary and interprofessional team. This is something that really each member of the team has something valuable to contribute to the building of these programs, and that certainly has been true with our experience at MSK. And all throughout the day, I've heard each and every speaker really emphasize this point. And so for me, it's been important. And as I said, having that established that weekly meeting has been huge in terms of ensuring that the communication between the group is really tight. I guess to wrap up, I think I'd like to say that, CAR T, to be a part of CAR T programs has been such an exciting thing for me, being an oncology nurse for 20 years, to be a part of a therapy that's so emerging and new. And again, going back to my family, when I was talking to them about what this means for cancer treatment, I really explained to my husband what it was all about. He used an analogy that is a little ironic now that I find myself on the West Coast, but he talked about, that's kind of like in surfing, where you are on that edge of the surfboard with your toes hanging out over the edge and the waves coming up about behind you, and you have that perfect balance of being ahead of the curve and ahead of the wave. And if you can do that, you've really just achieved that perfect hang 10. And that's really what it feels like, is that we're just on this, sort of edge of something more and something new, and it's really just a rush and very exciting to be a part of. So I thank you for having me here today, and I welcome any questions you have.
Actually, I have a question regarding your screening. So you were only doing like it looks like a modified CAR-Tox 10 once a shift. Were you screening for any more frequently for anything else?
No, there's no more frequent screening for anything else, no.
So I guess when we heard the other talk, they were saying that within that first 48 hours, they have the fever and they have a higher risk of having CRS. So you're only really screening once a shift. So I feel like you might be missing a window where they may be actually going downhill, and I don't know.
Yeah, so I think a lot of that remains to be seen. So, believe it or not, this once a shift timing got tossed around a bunch of times, and that's sort of what we settled on for the neurotoxicity screening. I think that that's just based upon our experience so far, and will remain to be seen. But
even for other screening, were you doing vital signs every 4 hours? Are you doing any other screening other than that?
The vital signs every 4 hours, yes.
But that's okay. You're just making me nervous.
What are you doing?
Well,
right
doing
now
we're just about to start, and that's what we're trying to toy with. How often should we do screening, and what kind of screening? Because we were going to do CAR-Tox 10, but we also have a delirium screening we do once a shift.
Right.
So, and of course, they're on the stem cell unit, so they're always Q4 vitals anyway. So.
Right.
Okay, thanks.
You're welcome.
Hi, Richard Elkin from Montefiore. How did your contract managers become adept so quickly at the right contracts? How did they negotiate? You mentioned you are getting some reimbursement from Medicare, and how did they negotiate with the Medicaid HMOs? We're struggling with that right now.
Yeah, so the reimbursement that we received wasn't from Medicare yet, so it was one of our third-party payers. But, I think that everybody's just learning by doing, and I don't know that they've achieved it any quicker than others. It's really just kind of working and muddling through the process and trying to keep in close contact with these payers. Many of the payers we have relationships with, and I think, what I've heard them talk about is they actually, make those personal connections with people at the insurance companies, and when they have that, they've been able to move things along a little bit quicker at times. So having those relationships in place has actually been helpful.
Yeah, that's a good point. Thank you.
Yeah. So it was, what the slide depicted was 8 patients that we've actually discharged from care out of the 11. Not all 8 went to the ICU, but majority did. And what you suspect is correct. We did have a very low threshold for transferring patients to the ICU, and so I expect that might change over time. And I think in many cases the ICU stay elongated the total length of stay, yes.
How far are you going with the patients until you get that insurance approval? So like at our center, we are actually waiting until we have the SCAs and everything else worked out before we bring the patients in for intake and testing. I don't know if that's...
We're waiting for that as well, yeah. But it's hard. I mean, I think that's the piece that's hard, right? Because there's so many other things that you need to time along the way, and waiting for that is I think, big part of the complexity, and that's what our nurse coordinators are really responsible for managing.
Just really quickly on the scan tool that you guys are using, have you seen any more significant neurotoxicities that you've been able to catch using that scan tool versus just a normal neuro check that you might do?
So I'll have to get back to you on that, because we literally just approved the SOP about a week ago, and so we hadn't formally been using it. Some of our providers were using it more informally, but from nursing perspective, we had not implemented it yet, and I think it's only getting embedded into the documentation next week, and so we don't yet know, but that would be an interesting question to look at, if there are any differences in what we're catching based upon that tool. Thank you for asking that.
Hi, Dr. Rodriguez. Forgive me if I've got the numbers wrong, but it seemed like your 8 or 11 patients came from a pool of something like 66 to begin with that were being considered. And I'm just wondering, what has been the experience of the patients who have been found to be ineligible for whatever reason for the treatment? And has that been difficult for your staff?
Yeah, so it's the numbers are a little bit off, or the interpretation numbers are a little bit off. So the one screen that I showed of the dashboard was really a snapshot of last week in terms of total number of referrals we've received since 10 months ago, which was 66. And then what we currently had in sort of the pipeline, as we say, for commercial CAR T therapy, I think was around 18. The 11 is the number of patients that have actually received the drug, Yescarta, to date, and then 8 had been discharged. So, I think that it's a whole variety of things, really. Sometimes we're getting patients that are better suited for transplant, and so then we're setting them down that path. I mean, this is literally, the 66 is every single patient that calls the 1-800 number, or provider that calls the 1-800 number to be considered. So there's certainly a proportion of patients that have gone down that path. There's been patients that have opted out, and so removed themselves from consideration. I think there was one patient death before they were able to be reviewed for eligibility. So it's a real variety of different reasons.
I just wondered if you had to deal with dashed hopes, if that's a piece of the picture.
You know, I actually, one of my colleagues is here today, and she'll probably be, I'm gonna call out Megan, because Megan's one of our clinical nurse coordinators, and I don't know if she can speak a little bit to that, because that's a very valuable question, and Megan is, really at the front line of speaking with those patients in terms of what their expectations are, and thinking that, and I'll keep talking until she gets up to the microphone, and thinking that they might be eligible, and then after going through that screening process, learning they may not be. And Megan is working more with the pediatric patients, but she could probably speak a little bit to that.
I'm more on the pediatric side, so we haven't gotten as many phone calls as the adults, but it has been a little bit difficult talking to patients who are a little bit farther, even across the country, and telling them that, no, this isn't an appropriate therapy for them. We had a lot of calls regarding AML for the treatment, but we know that it's just for ALL, so yeah, that was a little hard. So.
Thanks, Megan.
Yeah.
Thanks, Liz. This is so great. It's so nice to be validated that we are all kind of working in the same space. But I had two questions. How do you work with your ED and your ICU departments, and how did you incorporate them in the planning? What kind of things did you feel like they needed up front? How did that change over time? And then the next piece is, what did you do to actually get your nurses who are administering the products ready? Yeah. Simulations, trainings, labeling, bedside verification, all that stuff.
Yeah. Great questions. I'm glad you asked, because I realized I forgot to mention, and this is partly working with the companies too. So we talked about REMS training today, and that's a big undertaking when you've got a large organization and hundreds of people to train. And I think particularly thinking about those ICU and for us as our urgent care staff who aren't regularly caring for these patients but might have to care for these patients, and sort of getting them on board. One of the things that Kite wanted us to do off the bat was do live training for all these people, and we knew that that really was not a reasonable ask. So after a lot of negotiation with them, we were able to put the education onto an online platform, which was huge in terms of the scaling of the education and being able to reach all the people that we needed to in a timely way. And I think it also is helpful for sort of sustainability over time as staff turnover. The other weekly meeting that we have, Karen, is actually nursing education, and it's very specific to CAR T. So we have our Monday sort of multidisciplinary meetings, and then on Tuesday is our nursing education meetings, and that's really a collaboration between our nursing professional development specialists, our clinical nurse specialists across the continuums of care, coming together to do all of those things, develop some in-services that augment the REMS training, the in-person hands-on training around administration of the cells, and just sort of that one-to-one working with them on the unit face-to-face. It's quite labor-intensive, actually, and I think that what remains over time is how we'll kind of sustain this. I don't know what the answer is. I think that we'll have to see, but we've limited the admission of these patients to certain floors, so I think that's been helpful in terms of targeting groups of nurses in the inpatient setting, but still we know that things happen. We actually had, in our first group of patients, we had a patient transferred to a different unit because they needed telemetry monitoring to a unit that hadn't had nurses that had been trained. So that was a mistake, but it was sort of in the moment. I think it was a night or a weekend, and they needed escalation of care, needed to go to the telemetry unit, and ended up on a unit that they shouldn't have been on. So these are sort of our lessons learned over time in terms of trying to reach all the people we need to for education.
How many CAR patients are you treating at the same?
Yeah, we're trying to limit that to 1 or 2 patients a week at the most. I don't know the answer to that question. They've all been treated inpatient, and they've all been treated on our hem-onc units. So it's not something that I've heard that they've been doing, but I don't know for sure. They work outpatient primarily. Go ahead.
Sorry, one
No,
last
this is
question.
great. Thanks.
So what have you found when you're doing the SCAs in terms of our kind of quandary has been trying to expedite patients who are very sick and getting to an agreement quickly while not setting a precedent and saying, okay, we're going to take more of a loss on this patient to get them through, but we don't want that to be what the reimbursement is going to be moving forward. I don't know how you're dealing with that.
Yeah, I mean, there's really been no expediting, I would say, on our part. I think we're solely dependent on these third-party payers and the degree of speed that they'll work with us. I mean, I think you might have seen on the slide, we've had some success of getting things moved quickly, but I don't think that's because we've had a willingness to take a loss. We really are getting these authorizations in place before we're proceeding with any sort of workup or care. I think what we've been able to do, as I mentioned earlier, was, sometimes where we have relationships in place and literally we know people at the companies, that's what I've heard has been successful in terms of moving things along. There's also, if we've worked with one company with one patient already, when we come around to that second patient, that also we've seen the timing speed up a little bit more in those scenarios as well. But there's been, there's a variability of insurance coverage too. So I unfortunately don't see that repeat as much as we would like to. Yes? There was one, yes. I'm not. I'd have to double check that and let you know. They're not, so first of all, we haven't yet implemented, the scan score. We're about to next week. So they wouldn't have done that, but I can check to be sure. I don't want to misspeak. I'll make sure and get back to you on that.
Do you mind repeating the question for those of us in the back?
Sorry, Karen. The question was, we did have one patient out of the 8 patients who was readmitted after discharge, and the question was, what was the reason for readmission? And I just need to double check and get back to you on that.
My question is more about patient education. Did you create a program? What are you doing to educate patients on this?
So we at Memorial Sloan Kettering rely a lot on what we call fact cards. So they're essentially patient information sheets that we develop ourselves. And so that's what we've done for the CAR-T program as well. And we did, Megan actually was one of the nurses that worked on the development of these materials, and we hand out that to the patient. But I think probably equally or more important, depending on who you are as an adult learner, is that one-to-one relationship with that clinical nurse coordinator and really establishing that foundation of education at that first phone call before we've even decided whether the patient's, what path they're really going down. They're starting to do some education with the patient at that point in time. And then there's the one-to-one meetings in person where there's reinforcement of the education that's given. Anything else? Okay. Thank you.